Ready.
Okay, started your timer and here is your question.
Yeah.
Right, please.
Okay, so time start now. 6
Yes,
minutes.
21 seconds are left. 1 minute is
Okay.
started. I told you, you'll read question for 1 minute and then you'll enter inside. And then 6 minutes will start.
Okay.
Okay, now you can, if you have read and understood, considering it clinical examination station, kindly begin. So you'll enter, you'll
Hello.
introduce yourself. Yes, hello.
Hello, good day. My name is Kadi. I'm one of the surgical doctors looking after you.
Yes,
May you please confirm your name and age?
I'm Lisa, 62 years old.
All right, Lisa. Nice to meet you, and thank you for seeing me today. Today, I have been asked to examine a swelling in front of your neck that will know
Okay.
looking, feeling, and also I will feel with the help of my instrument, which is called a stethoscope. And I
Okay.
will also have to expose front of your neck. So would that be okay?
All right. Yes.
Okay, that's one perfect. Then we can start. First of all, I will just look from front. Okay. Okay, that's perfect. Now I will look from the side. Okay, now I will look from the other side. Okay, I'm coming back on the front. And now can you please, Lisa, stick out your tongue for me?
Yes.
Okay, that's great. Okay, now can you please try to swallow?
Yes.
Okay, that's
Done it.
great. Okay, okay. And now I will go behind and will look from behind. Okay.
Okay.
Okay, now coming on on back of your neck. Okay, now I just want to feel. So before starting feeling your swelling in neck, can you please tell me that do you have any pain previously?
No.
Okay, okay. Now I just want to feel on the right side first. Could you please turn your neck to right side?
Okay.
Okay, that's great. Now please turn your neck to left side.
Yes.
Okay, now I'm putting my hands on both sides. And can you please again stick out your tongue?
Yes.
Okay, that's great. And now put it back and now please try to swallow like before.
Okay.
Okay, that's brilliant. Okay, now I will tap with the help of
Swallow
my
or
finger.
take a sip of water.
Yeah, take a sip of water,
Yes.
please.
Yes. Done.
Okay, that's perfect. Okay, now I will tap with the help of my fingers on your upper chest. Okay.
Okay. And
Okay.
say
Okay.
another
Please.
thing, if it hurts you or gives you any kind of discomfort, do let me know.
Okay. Okay.
Then you'll
Okay.
stop. Yes.
Okay, I'm going to tap my fingers on your upper chest, and if it hurts you, please let me know. I'll stop.
Okay.
Okay, okay, that's perfect. Okay, now I will use my instrument, and I will feel swelling from sides. Okay, okay, perfect. Now on the left side. Okay, that's great. Now I want to feel glands in your neck, Lisa.
Okay.
Okay, are you comfortable, Lisa?
Yes.
Okay, that's great. Okay, feeling your cervical glands. All right, perfect. Could you please shrug your shoulders? Just
Okay.
want to feel gland. Okay.
How would
Okay,
you
that's-
say? Okay, or shrug, yeah, or raise your shoulders upwards. Okay, good. Yes, and
I think raising shoulder would be better for
yes,
supraclavicular lymph nodes.
yes.
Yeah. Okay.
What
Now I
more
will
would you?
come.
Yes.
Now I will come in your front.
Yes.
Could you please stick out your hands for me?
Yes.
Okay, that's
Stick out,
brilliant.
stretch out your hands. Yes.
Okay, okay. And now I just want to feel your palms if there is any sweating. Okay, Lisa.
Yes.
Right side, left side. Now I will feel your pulse starting from the right side,
Yes.
then on left side. Okay, Lisa, now I will put a piece of paper on your stretched arms. Okay?
Hands. Stretched hands. Yes. Yes.
Yes, sir. Thanks. Okay, so here I'm going to put. Okay, I just want to look. Okay, that's perfect. Now I'm taking it back. All right. Okay, Lisa, can you please now follow my finger with help of your eyes?
Okay.
Okay, perfect. It's going to the right, then up, then downwards, and in between, then left finger going up to side, left side upwards, downward, and in between. Okay, that's perfect.
Yes.
Okay. Now I just want to look your legs.
Okay.
Could you please
Roll up your pant.
roll up your
Yes.
trouser?
Yes.
Okay. Okay, that's great. I just want
Right.
to.
So can you please summarize your examination now? Time has gone.
All right.
Yes.
To complete my examination, I should have also done the lid lag, and I should have completely checked the peripheries.
Yes.
And to complete my examination, I would also need a radiological review and ultrasound report and some blood investigations. So
Okay.
I have just I have just done examination of the thyroid gland in this lady, and on examination, on inspection, there is swelling in front of neck, and swelling was movable with swelling, and on palpation, there was a slight increase in temperature in comparison to the surroundings, and on percussion, there was no significant finding, and on auscultation, I could not find any significant findings, and there was a tremor. Then I noticed in her hand, and pulse was rapid. So my main provisional diagnosis
Yes.
for this patient is simple multinodular goiter, and other
Okay.
differential could be.
So what are the other differential diagnoses that you'll consider?
Yeah, other could be like toxic multinodular goiter,
Yes.
and thyroid neoplasm,
Yes.
uh, and thyroglossal cyst. I will
Okay.
also
Good.
rule out that.
How do you plan to manage this patient now?
Okay, for the management of this patient, I will start first of all with the triple assessment.
Very good.
I will take a detailed history and examination, a detailed examination, and then a radiological examination, and I will take a sample for fine needle aspiration cytology. I will do ultrasound of the neck, and then I will order some blood investigation like full blood count, thyroid function test, and I will also consider these with my senior. And
Yes.
for the management, first of all, I will start for the treatment. I will start with the drugs such as thiopurines, beta blockers, radioactive iodine, and then I will consider the surgery after discussion with the anesthetist and discussion with my senior, and I will go for the definite surgical plan, and that will involve total or hemithyroidectomy.
Okay. Can you please tell me, once you ask for FNA, report comes back and it says follicular cell tumor, what does it mean? And that it is unable to differentiate carcinoma from adenoma. How would you interpret the report?
After seeing that, if I wouldn't be able to differentiate, I will order histology rather
Very
than
good. Cytology. Very good. Excellent. Okay, time has ended. So can you please tell me what are the things, if you can, because it was very nice things that you couldn't cover. You told me at the end that if time would have allowed you, you would have completed with everything that you needed. But once you were summarizing, I'll begin from there, because examination, it doesn't matter how, in which order you examine. As much as like the stem that you have read outside the bay, and you have made the right diagnosis, and you have given the right conclusion of the examination. Here you said it's a swelling, but you forgot to tell me the size of the swelling, because you have palpated. So you should have told me 4 by 6 or whatever is the dimension of the swelling that you felt. And if the swelling, how was it? Like, was it soft? Was it consistent? Was it like, how was the surface? If the overlying skin was attached or was movable, how was the surface? Like size, like this you have to mention,
all
right?
those 6S.
Yes, all S. You didn't. You did tell me there is a swelling, but not much. You didn't feel for the temperature. You did ask for tenderness, right? So tenderness you checked, you confirmed, but temperature you didn't tell me. The edges, consistency, pulsatility, if there was any pulsatility, if it swelling was reducible or compressible, was it mobile or was it fixed, adherent? This you couldn't tell. Exophthalmos, you were trying to, yeah, you did say something about it. You didn't check for trachea if it was central or it has been shifted because of the swelling. You know, sometimes it can even happen like this. You didn't auscultate for bruit, the swelling. And for the thyroid status, okay, when you were doing examination of the hand, you took the pulse, radial pulse. You should have taken biceps reflex as well. When you were, yeah, you were examining a lid, leg, and eye movement. Okay, that's good. And when you were examining leg, you did check for pretibial myxedema, but you forgot to check knee reflex. And you didn't mention proximal myopathy. Right. And yeah, when you were, yes, like once you were introducing yourself or taking permission, you did say you need to, a patient needs to open 1 or 2 buttons to for the examination. So that kind of, yeah, covers, but you should have mentioned patient will be sitting. Yeah, good. So these are the small things which can be improved with second division. Yeah, definitely.
Yeah, these were deficiencies, and I think I auscultated, but I
did
didn't
not
tell
mention. Yes.
it.
In the last 2 minutes, when I asked you to summarize your examination, then you have to tell the important things, that there was no bruit, or if you felt bruit, any carotid, if there was any bruit or anything, because here you have to look for carotid pulse as well. So if there was any pulsation, carotid pulsation or not. So like these are all examination that you have to do quickly in 6 minutes. Yeah, very good. Any question that you have?
Well, 6S was a main mistake, because I even didn't think that I should follow all the protocol of swelling and going like that, like
Yeah.
what rotate and submandibular. So it should be also be considered like that. So that was a major mistake. And And what we do for proximal myopathy, ma'am?
How do you do it?
Yeah, ma'am. How we will do proximal? How we will
Would
check
you ask
proximal myopathy?
you would ask the patient, would you please expose your leg? I will take a close look at your leg. So if there is proximal myopathy, so how a patient with myopathy appears? And what does proximal means?
About
So once you're, yeah,
muscle weakness.
Shrinkage.
There is
Yes, there is
shrinkage.
shrinkage. Yes, size will be less.
Okay.
Normally, you look at the legs, normal legs, you see, or you can compare both legs and you see the difference, like if there is any difference, or the legs look shrunken, like they're drained out, they're shrunken, they're less in size, or they are of the same size. So you can look and you can compare. But then you would have to ask the patient to roll up the trouser, so the knee, up to the knee, whole thing is exposed. And then you have, once you are doing this, then you have to do the knee reflex as well. How the reflexes are affected if a patient has any thyroid condition. If patient has hypothyroidism, yes.
How be exaggerated?
Tell me, you tell me. I'm asking.
Like when I will tap the hammer.
And how is, what is the difference? Like hypothyroidism? Yes, please, sorry.
Okay, so ma'am, in hyperthyroidism, it would be exaggerated. Like I will, when I will tap,
or hypo.
Sorry, in hyperthyroidism, it would be exaggerated.
Yes.
When I tap the, and then it would be more.
Yes.
More response. In
Yes.
hypothyroidism, it
will be sluggish. Yes.
Yes.
Good. Thank you. Okay, started your timer, and here is your question. Time started. Yes.
Okay.
Right. So if you have read and understood, considering it critical care scenario, kindly tell me, how would you manage this patient now?
Okay, I will manage this patient according to as the patient is critically ill. So I'll manage him according to the care of a critically ill surgical patient. Following the immediate assessment, I will do the A, B, C, D, E in the airway. I'll be checking for the, I would look for presence of central cyanosis, uses of accessory muscles of respiration, altered level of consciousness, and then any obstruction by foreign body or vomitus. And I will listen for abnormal sounds such as snoring, hoarseness of voice or stridor. And I will feel over the cheeks for airflow on inspiration and expiration. And then if there is any problem,
yes, please. If you find patient having difficulty in breathing and you find inhalational injury as well, what would be your next step of management?
Okay, the next step, I will immediately, I will secure and I will give the patient oxygen to prevent hypoxic brain damage. I will start with high flow oxygen over.
Very good. Yes.
Using a reservoir bag. Then I will use simple methods of obtaining airway like chin lift or jaw thrusts.
Yes.
Or if the patient hasn't tolerated it, then I will go to either Guidel airway or nasopharyngeal airway.
Okay.
And if the patient still is not, the airway is not patent, then I will go for more complex methods of
With your
CPR than any
yes, with your further examination, you realize patient has airway edema. What would you do next?
I will go for, I will consult
Intubation.
the anesthetist and I will
Yeah.
go for a surgical tracheotomy.
Yeah, good. Okay. Right. Can you tell me how would you take care of the nutritional status of the patient or
Okay.
nutritional management? Yes.
Okay, as the patient is critically ill, it
Yes.
will involve communicating with the dietitians, a multidisciplinary team approach. The
Okay.
nutritional requirement will be either by using a TPN,
Yes. And
total parenteral nutrition,
yes.
so that the patient can get his adequate caloric needs.
Okay. How would you calculate the need which is required for this particular patient?
Okay, the requirements can be done using the requirement for patients is usually 30 to 50 calorie per kg per day.
Okay, can you please tell me how would you assess the adequacy of the fluid therapy which is given?
Okay, adequacy of the fluid therapy, I will for the fluids requirement of the patient, I will use either the Londa-Bond chart or the Wallace rules of 9 to calculate the fluid requirement of the patient.
Okay, that was answer to the previous question. For this one, you look at the losses, okay, urine output,
Yeah.
and peripheral warmth, and what else? Core temperature and hematocrit,
Yeah.
etc. Okay, all right. We'll come to another question. Kindly tell me what are the complications of the burn that you expect to see in this patient?
Okay, as this patient has soot in his nostrils, so
yes,
complications can include airway edema and compromise.
Yes.
It can also include it can also include sepsis.
Yes.
Wound infection. Yes.
Can you tell me what you understand by the term ARDS, Adult Respiratory Distress Syndrome?
Okay. ARDS, Adult Respiratory Distress Syndrome, is it's inflammation of the
No, it's not inflammation. It's a condition. Yeah. What happens in it? Yes. How yes.
There is usually swelling of the alveoli, a lack of perfusion.
Yes. You can say there's yes, severe lung injury, yes. Which is progressive and all right.
It's a severe lung injury, which is there's diffuse alveolar damage and capillary.
All right. Can you please tell me what are the causes behind it?
Okay, causes of ARDS.
Yes, please.
Okay, causes of ARDS can either be pancreatitis, burns.
Yes.
It can also be due to.
If you can classify it into
sepsis.
two, because of direct injury or because of indirect systemic
direct
conditions.
Injury direct injury like trauma, pulmonary
inhalation injury, yes.
Inhalation injury, and then fractures to the ribs, and then systemic injuries like sepsis, gastric aspiration, pancreatitis,
etc. How should ARDS be managed? What is the correct?
Initially, we are following the CRISP protocol, immediate management, ABCD of resuscitation. Then we will ventilate the patient, respiratory support using positive end pressure and expiratory pressure ventilation.
Yes.
And then we will give steroids, low dose steroids. And then we will give IV fluids, and then nutritional management, and then we will prevent VTE.
What should be the last resort if a patient comes to you with ARDS and has profound refractory hypoxemia? How would you manage that?
Can you come again?
Yes, if this same patient has profound refractory hypoxemia, and all the measures
Yes.
that you have taken in ARDS, they are of vain. The patient is not being managed. What is the last resort that you would do? What is the last management step that can be done?
Okay.
You'll do ECMO. Okay.
And
We'll-
we will.
We'll come back. Will ask me, can you please tell me what is Berlin's criteria?
Berlin's criteria is for ARDS based on the ratio of inspired oxygen and partial pressure of oxygen to mild, moderate, and severe. So in mild ARDS, in Berlin criteria, the ratio of PO2 to inspired oxygen is like 200 to 300, while in moderate is like 100 to 200, while in
Can
severe
you
is
please
less
tell
than
me,
100.
yes, what are the conditions that you'll consider to determine if the burn injury is second degree burn or not? What are the things that you look at?
I will look at the overlying skin.
Okay, and
I will look
extent
at
and
the
depth. Okay,
yes, and the depth of the burn.
right, good. Can you, last question, Bell is gone, but kindly tell me what is the criteria to admit a patient in the burn unit?
Okay,
Please.
criteria for specialist burn transfer or
Yeah, to transfer
burn.
or admit the patient in the burn unit, because
Okay, full thickness burns to the
okay,
face, limbs, and the genital area.
where exactly? Okay, face, genitalia, yes, and
then the limbs.
okay, and next point.
And
please.
then age more than
very good.
65 or less than 50.
Okay, very
And then
good.
yes,
And?
I think that's the ones that I can remember. And then electrical burns.
Okay, or chemical.
And then any burn which burn surface area of more than 35% in adults, more than 10% in children.
Good. Good.
And then any burns affecting the airway.
Can you please
airway
help me
compromise.
to read this X-ray or this image, please? What can you see?
Okay, this is an X-ray of. Okay, there is no name, no age.
There's no name. Yes.
Taken. Okay, there is diffuse pulmonary infiltrates on the X-ray.
Yes. Yes.
So likely
And
this is due to the ARDS.
what else can you
And
see?
then I can see a tube.
Okay.
That
Tube,
likely a pulmonary wedge catheter.
Okay.
And then
yes. What else? Can you see some deformity over here?
Yes.
Yes.
There's
what?
loss of no.
Yes, your friends can help you. Do you know the A, B, C, D of reading X-rays?
Yes.
Can you?
Airway.
Yes. Think like that and tell me if there is anything else you can mention.
Okay. So A, the trachea is central. B, there's no fractures.
Yeah.
C, goes there. There's air under the left diaphragm. Then there's blunting of the cardiophrenic angle.
Basically, this is of ARDS, and you can read more on it, what to look for in the X-ray, because at least 4 to 5 things you have to tell. So we can discuss that tomorrow.
Yeah.
Good. Thank you.
Okay. Thank you.